Welcome to today's webinar, The Opioid Crisis, Considerations for Chronic Pain Management, hosted by the National Safety Council, a leading advocate for safety in the United States and the DuPage County Health Department. Since 2012, as part of our mission to eliminate preventable death, the Council's Prescription Drug Overdose Initiative work to reduce opioid-related injuries and deaths by educating the public about the risks of opioid pain medications and how to protect themselves and their families, increasing access to affordable and effective substance use treatment, and promoting safer opioid prescribing practices. Activities to promote safer opioid prescribing include funding and sponsoring a systematic evidence review on acute pain treatment with American College of Physicians and the American Academy of Family Physicians, and supporting the work of the NSC Physician Speakers Bureau to educate their peers on opioid prescribing best practices. Today's webinar speaker, Dr. Fink, is a member of the Speakers Bureau. A few housekeeping matters before we begin. If you experience any problems during the presentation, please contact technical support at 877-297-2901. We welcome your questions and comments at any time during the web presentation. You may submit questions electronically by typing them into the chat pod located in the lower left corner of your screen. If you're having difficulty seeing the entire slide, please click the scale button in the upper right-hand corner. Questions will be addressed in the question and answer session at the end of the presentation. The link to the recording and slides from today's presentation will be emailed to all attendees. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the Accreditation Council for Continuing Medical Education through the joint providership of the Illinois Academy of Family Physicians and the National Safety Council. The Illinois Academy of Family Physicians is accredited by the ACCME to provide continuing medical education for physicians, and for those of you seeking CMEs for the presentation, please provide your contact information and post-webinar survey so we can mail you your certificate. The Illinois Academy of Family Physicians designates this Internet live course, The Opioid Crisis, Considerations for Chronic Pain Management, for a maximum of 1.5 AMA PRA Category 1 credits. Today's webinar is made possible by funding through a prevention grant from the Illinois Department of Human Services, Department of Alcoholism and Substance Abuse. Now I'll turn it over to Mia Sagalis, Director of Community Initiatives at the DuPage County Health Department, to set the stage for today's presentation.
Thank you, Wendy. Hello, my name is Mila Sagalis. Good afternoon. We wanted to talk today about some of the goals we had regarding prescriber education. The Health Department has been actively involved in working with stakeholders since 2013, looking at how we can best address the opioid crisis in DuPage County. With some goals around education, quickly we went and started talking to prescribers. And with some partnerships with local partners and with SAMHSA, we were able to provide an in-person training and CME event in May of 2014. And at that time, the CDC guidelines had yet to come out. So we first started talking about what the Joint Commission standards were, how safe prescribing was a strategy to prevent overdose, and how important use of the PDMP was in practice, and also for data collection. After feedback from that in-person training, when we had about 100 people providing some evaluation, we provided some webinars to address some subject matter content that was specific to different sectors like oral health, in particular dentists and their prescribing practices, and then later looking at how addiction and adolescence and how brain science were connected to opioid use and things like that. Moving into May of 2017, just recently, the Health Department partnered with the National Safety Council, and with their shared mission of impacting opioid use and prescriber habits, we were able to have a second in-person CME event, and that was held here in Addison, Illinois, with about 150 practitioners. That event focused on the role of public health and the opioid response, pain control versus euphoria, and the role of primary care physicians in treating and managing chronic pain. And again, we looked at the role of the PDMP, and specifically in Illinois, how funds are being used to address the opioid crisis, which led us to our webinar today talking about tapering as we looked at how we can further impact opioids and prescribing habits, and also to support the feedback that we had from people that were in person at the event in May. In DuPage County, as I mentioned, local stakeholders and leaders have been looking at opioid deaths and overdoses since 2013. Our coroner, Dr. Richard Jorgensen, supplied the data that you see here, looking at how deaths have increased over the years. In 2013, what kind of got us kicked off on this topic was we had, in the middle of the year of 2013, in June and July, an increase in deaths, a sharp increase. And that was due to heroin coming into DuPage County and impacting how people were actually just overdose deaths in general. And then that number, we took a short dip in 2014, but in 2015 and 2016, we've had an increase. And since then, although the slide here says DuPage County heroin deaths, we know that in 2015 and 2016, fentanyl has had an impact on the overdose deaths that we've seen. So we didn't have the fentanyl numbers early on in this graph, but in 2015 and 2016, we did see fentanyl deaths increasing, and we started to collect that data in this graph here. This next slide looks at the drug overdose mortality in DuPage County and puts it into perspective with local information from Illinois and then across the country in the U.S. So although DuPage is underneath the state and the national numbers, the rate is still increasing, and you can see that goes back to 2008, all the way to 2015. So with that, I'm going to turn over our slides and our information today to Dr. Fink. And just give me 1 second to pull up his bio. Dr. Ezekiel Fink is triple board certified in neurology, pain medicine, and brain injury medicine. He serves as the medical director of pain management at the Houston Methodist 7 hospitals and its outpatient clinics. He is also an assistant clinical professor at UCLA. He is widely published in the field of pain management and spends substantial time on policy work, including extensive expert review and educational work with the California Medical Board and Department of Justice. Dr. Fink works with clinical and public health entities on issues regarding the opioid epidemic and proper opioid prescribing. Thank you for joining us, Dr. Fink.
Thank you so much, and thanks everybody who's participating here. Hopefully I can give you some helpful information for your practice. So the slides are not advancing for me right now.
Would you like me to advance them for you?
That'd be great.
Okay.
Okay, so I'm going to briefly go through the objectives of this talk. There are 7 objectives that we hope to accomplish here. 1 is to identify the history and scope of the opioid epidemic. 2 is to describe pain and effective ways to treat it. 3, identify the benefits and risks of opioid and non-opioid analgesics. 4, apply evidence-based guidelines and approaches. Next slide, please. 5 is describe the prescriber's role in combating the opioid epidemic. 6 is to educate patients on opioid use, risks, and alternatives. And 7 is to describe medications and when to refer to pain management and addiction treatment services. So with that, let's begin. Next slide, please. So this slide gives you a graphic of the rates of opioid overdose deaths, sales, and treatment admissions. And if you look, there are 3 colored lines here that actually are moving in parallel. And if you look at the bottom key, you can see that we're dealing with the morbidity and mortality associated with opioids in the green and purple lines, but that is in parallel to the orange line, which is the opioid sales in kilograms. So there's always the discussion of causation versus correlation in the field of medicine. The example that I remember from way back in my days in medical school was the auto manufacturer Volvo wanted to capitalize on their lower rate of accidents, so they began saying that it's the safest car on the road. But if you think of the sort of person that drives a Volvo, it's typically not a teenager's first choice for car. So it could have been a correlation, and they took advantage of it and said causation. In this particular case, we have three of these lines traveling in parallel. I think it's beyond coincidence. And certainly, if you look at the overall statistics, we have 5% of the world's population. We consume 80% of the world's opioids. There is a pattern here, and certainly we know that more opioids consumed leads to more morbidity and mortality. So I think there is definitely a relationship between these three lines. If we can move on to the next slide, please. So how did we get here? So prior to the 1990s, opioids were really not widely marketed or used outside of cancer pain. And in the 1990s, there were a couple of research articles that I think did not really address the issue of addiction as thoroughly as they should have, and led to the conclusion that opioids, when used for pain, based on subjective reporting, have a very low rate of addiction and a low risk of addiction. And unfortunately, this information was taken by big pharma, most notably Purdue Pharma, the manufacturer of OxyContin, which launched an advertising campaign touting this low risk of addiction, which I think they said was 1%, and improved the functional status of patients. So they used these talking points, which led to a skyrocketing in the use of pain medications, specifically opioids, for the treatment of pain. This information was misleading, and it gave physicians a false sense of security about using opioids. This was followed up in 2001 by the Joint Commission, which rolled out its pain management standard, which were promoted by the idea of pain as the fifth vital sign. And I just want you to think about the implications of that. If we think about what vital signs are, respiratory rate, heart rate, and then we put pain in there, think about how we're treating this as this subjective piece of data as such a fundamental component of patient care, and you tie that in with the reported low risk of addiction with the opioids, and unfortunately it really contributed strongly to our current circumstances. The perception back then was that pain was grossly undertreated, and all of these factors contributed to there being ease of access to opioids without substantial concern over the implications of that the access. I do have to say that I am board certified in pain management, and from the late 90s to the early 2000s was really, I think, the birth of pain management as a field. And I think that overall there is a greater recognition among clinicians about pain. I think clinicians and patients are more freely sharing that they have pain. Clinicians are taking it as a serious complaint. So I think there is a silver lining here. I think we have to redirect how we address the issue of pain. But I do think that pain as a symptom is very serious, and hopefully we can redirect it and treat it more effectively and more safely. Next slide, please.
Mila, can you advance that for him, please? My internet just froze.
Okay. So the issue of addiction is front and center when it comes to opioids, and we started the talk with a couple of slides about heroin. And the question is, well, how do we get to heroin? And unfortunately, there are multiple gateway substances to heroin, and patients who use heroin unfortunately have used at least one other drug, and many report using 3 other drugs. If you look at the other substances that are consumed and patients can get addicted to, this actually includes stuff as readily available as alcohol, if you look all the way on the left. But if you look all the way to the right, prescription opioid painkillers have been shown to be the gateway substance for multiple heroin users. As of a couple of years ago, upwards of 75% of patients who were addicted to heroin said that prescription opioids were their gateway medication. Now, unfortunately, heroin has taken on a life of its own at this point, and there are it sort of is traveling along its own curve, and the prescription painkillers are no longer necessarily the gateway medication for that. Next slide, please. So at this point, I want to review the CDC guidelines. This set of guidelines, which was released, I believe, in March of 2016, is not without its controversy. I think overall it was a very positive step because it gives us a playbook to call from. And I have done work with the California Medical Board and the Texas Medical Board, but I've worked with the California Medical Board on physician standards for over a decade at this point. And oftentimes I would see a chart where a physician was prescribing a substantial amount of opioids, and usually the clinician would say, well, show me where I can't give that amount of opioids. Show me where the standards are. And there really wasn't a published single standard on the appropriate doses of opioid medications. And a lot of doctors, and there are multiple research studies on this, a lot of doctors are actually trying to meet their patients' expectations when they manage a complaint. And I think that putting out guidelines such as this help clinicians define what their care should be, and also it provides a discussion point for a patient who says, I want more Norco, for example, or I want more Percocet. I think more would help me. It gives the clinician a talking point and a reasonable way to say, look, going beyond 3 a day or 4 a day, I think is not a great decision. I think it increases the morbidity and the mortality, and I'm actually doing things consistent with the way the CDC is recommending. So I do think that overall this was a very positive step for medicine and for patients. Next slide, please. So if you break down what the CDC guidelines are trying to do, I think that there are 3 general concepts that are being accomplished with it. One is a selection of therapy, one is establishment of treatment goals, and the other is discussion of risks and benefits. Next slide, please. So recommendation number 1. So non-pharmacologic therapy and non-opioid pharmacologic therapy are preferred for chronic pain. And I think that there was a paradigm, and this was very much reinforced by there being not accurate information on the safety of opioids, but also on insurance willingness to actually make these prescriptions available. So I think as a clinician, you knew that if a patient came into your office with a pain complaint and you gave them a prescription for opioids, you felt that you were both addressing the 5th vital sign, as it were. You're giving them a prescription for something that didn't necessarily carry tremendous risk with it, and the patients were satisfied with it. Also, I don't know if this seems to be a common experience, but trying to get physical therapy approved through an insurance company or trying to get another modality can oftentimes be complicated. It's not just writing a prescription where the patient will leave your office and they'll feel happy with the decision, and you won't get a follow-up phone call where they're asking you to fill out a prior authorization. So there were multiple factors that I think contributed to perhaps the medical community moving away from recommendation number 1. But as we revisit this topic, I think it makes very good sense that we should try non-pharmacologic therapy prior to any pharmacologic therapy, especially the more that we learn about all the medications we give, it seems, on a daily basis. And then non-opioid pharmacologic therapy, now that we have a good sense of the difficulties that are associated with opioids, trying other medications, I think, makes very good sense. Certainly, we need the insurance industry to step up and assist us in trying to provide this type of management. The next subset of recommendation number 1, clinicians should consider opioid therapy only if expected benefits for both pain and function are anticipated to outweigh risks to the patient. So this, I think, is sort of a basic tenet of medicine, but the question is, well, how do we get that done? And I think that there is, and I'm going to mention some things in this recommendation, and there is overlap between the different recommendations in the CDC, but assessing risk, I think, includes looking up a prescription monitoring database, doing a urine drug screen, taking an appropriate history, including whether a patient has a prior history of substance abuse or a psychiatric history. So there are multiple data points that help inform the risk to the patient. The other important thing here is, as of 10 years ago, if a patient walked into my office, I would ask them what their pain score was. If they said, let's say, an 8, and I gave them a pain prescription, and they came back at the next appointment and told me that their pain score was 4, I would consider that to be a victory. But as we know now, the pain score is, I think we've always known that it's an imperfect tool, but the question of function, I think, becomes a very important question. If that same patient is just sitting on the couch between my first and second interaction, for that month, the fact that their pain improved is not enough. We need to be focusing on function and setting functional goals for patients to justify the use of this medication, especially as we recognize the risk with these medications. And then finally, if opioids are used, they should be combined with non-pharmacologic therapy and non-opioid pharmacologic therapy as appropriate. And I think that the subtext here is, even if we make the decision to prescribe opioids, and in some cases opioids are appropriate, anything that we can do to lessen the amount of medication that's given, we should proactively be doing. Next slide, please. So recommendation number 2, treatment goals established before starting, pain and function. So I think setting the stage and setting expectations with patients is everything. And if they understand in the first appointment that you're expecting them to demonstrate increased function, and that's going to be the justification for the continued use of the medication, it makes it a much easier discussion if they don't meet those goals for you to say, I'm not sure this is the right medication for you. But that's an important conversation to have when the medication is initiated, and especially if it's going to be used as the marker for whether or not the medication is continued. And all this is predicated on the patient's understanding just how substantial the risk is with these medications. So that's also a very important conversation to have up front. The opioid agreement, the opioid contract, can actually really help with that discussion. Having the patient co-sign that agreement can have them understand just how serious this is. But I think having that ongoing conversation of whether or not the medication is justified is critical. And it's also a paradigm shift. Certainly 10 years ago, we would operate off pain scores. If a patient came in, I think we would far more liberally increase the medication. But at this point, I think that prior to initiating the medication, we want to have the conversation of how we're going to make the determination to continue it. And we're also going to have, it's also important to have the conversation of the maximum amounts of medication we're going to be giving. That if a patient doesn't respond to, say, 3 or 4 Norco for a complaint that justifies the use of the medication, that doesn't mean that we're going up to 5 and that we're starting OxyContin. That most likely means that this is not the appropriate therapy for them. Next slide, please. So the definition of opioids. So opiates, with the T, are alkaloid compounds found naturally in the opium poppy plant, and that's pictured all the way to the left. The broader term opioid includes all drugs with morphine-like effects, and that includes the semi-synthetic opioids derived from the opiates, like heroin and hydrocodone, and the synthetic opioids like fentanyl. For the purpose of this talk, I'm going to be using the term opioids. Next slide, please. So, state of U.S. health years lived with disability. This is an interesting slide because it juxtaposes the 1990s to 2010. Now, there are some takeaways here that I think help illustrate some of the points I'm trying to make in this talk, but by no means is this graph definitive. But I think the overall idea behind this is between 1990 and 2010, there was the introduction, the liberal introduction of use of opioids. So if a patient came in and said, I have pain, I think a clinician would make the decision to initiate opioids. They'd probably be more liberal in increasing that dose based on further complaints of pain. And the idea that was pushed that these are not very risky medications when it comes to addiction and that they improved patients' function, I think has been shown to be sort of a flawed premise. But a slide like this shows that over this 20-year period, despite the introduction of this medication, and if you remember that one of those first pictures that I show, which showed the increase in kilogram doses of opioids over time, and it looked like it doubled over the course of a decade, and in that time, morbidity and mortality also doubled. Well, we didn't get an improvement in the years lived with disability. So that, this I think really is meant to hammer home the point that the opioids are not in and of themselves phenomenal treatments for improved function. We have to track that, and we have to hold patients to it as a goal for the treatment with this therapy. Next slide, please. So there are a couple slides throughout this talk which are either reviews or summaries of slides that are about to come up. This is one of those slides. So we're going to be talking a little bit about how to select opioids, what the dosage should be, what the duration of treatment should be, and how the patient should be followed up. Next slide, please. So recommendation number 3. Before starting and periodically during opioid therapy, discuss with patients known risks and benefits. So this is a critical component for making patients understand the risk, but it also sets the stage for how you're going to be using these medications and whether you're going to be removing these medications. I think back about a decade ago. I think it would be almost unheard of for you at an appointment to say, oh, 3-Norco didn't work for you, I think this is not the right therapy for you. And I think a lot of patients have this expectation now that once they get this medication, it's going to keep going up, and that they don't really have a responsibility attached to the medication. So I think that we have to shift the paradigm here, where we're letting patients know what the risks and benefits are and discussing these other factors. And I think the opioid agreement, the opioid contract, helps really solidify this. And that should be periodically reviewed, and it should be periodically signed by the patient and co-signed by the clinician, just to reinforce the fact that these are serious medications, they carry serious risks, and the benefits really have to justify the continued use of the medication. Next slide, please. Recommendation number 4, when starting opioid therapy for chronic pain, clinicians should prescribe immediate release opioids instead of extended release long-acting opioids. So this is, I think, also a paradigm shift. I think that it seems somewhat straightforward and obvious that you should go with an immediate release medication, but I have to tell you, I've certainly inherited many patients that come in just on a long-acting opioid or have only been giving long-acting opioids. So as a general recommendation, we should really be treating patients with immediate release opioids and hopefully not moving on to the extended release formulations unless it's critically necessary. Next slide, please. When opioids are started, clinicians should prescribe the lowest effective dosage. And in your mind, before starting, you should have some idea of what those cutoffs should be. I think that there is a lot of work being done in the electronic health record space. I know not everybody has electronic health records. We are operating under this morphine milligram equivalent MME of 50 and 90. If you have an electronic health record, I think that all of them are going to soon have that functionality in the record, so you're going to be able to see, based on what you're prescribing, what other people are prescribing, what those numbers are. But for those who don't have it, there are conversion tables, and instead of using the conversion table every time, I think a practical way to just be on top of what MME your patient is on is just do a gross calculation of the medications you see most commonly. So for Norco, which uses hydrocodone, that's 3 to 4 tabs a day. Same with oxycodone. If it's dilaudid, it's going to be that's typically in 2 milligram tablets. So and if it's an immediate release morphine, well, your work's already done for you. But I think just have just write out very quickly. You could sit down once with it and just come up with a table of how many pills equals 50 MME, and that way, when a patient comes in, you won't have to struggle to figure that out in the moment. But I think for all of us, these are goals that we should set for ourselves. Now, I think one of the important points that I want to make during this presentation is that with the current concern over use of opioids, the general idea is not that patients don't require opioids. Some patients really require opioids for pain management, and it could be the most effective therapy that they have. But we have to create an environment where we're prescribing these things, these medications, in the most effective way possible, and we're limiting how much we give out. So a patient may require more than 50 MME, but if that occurs, I would encourage the clinician doing that to document why that is. So I would treat 50 as a number where above that it requires a justification. And if a clinician, if somebody requires more than 90 MME, same thing. I think that requires a written justification and a continued justification, because these numbers are based on increased morbidity and mortality for patients. If you look at there's a nice slogan right at the bottom of the slide: start low and go slow. So one of the challenges that I think we face as a medical community is those patients who came along during the 90s and early 2000s that were managed in the old paradigm. And now we're coming back and saying, I think we have to change the way we manage your medications. And I know with patients that I have had that conversation with, they're not always thrilled to have that conversation. But still, it's an important conversation to have, and as best we can, we need to bring them up to speed with the current set of recommendations. But one of the most effective uses of all these recommendations and all this new information is on the new cohort of medications. So that new patient coming into your office with back pain, with some chronic pain issue, we have all of this new information, and hopefully they never wind up having issues with the medications we prescribe. Next slide, please. Recommendation number 6. Long-term opioid use often begins with treatment of acute pain. So the data shows that if a patient is on a medication for more than 3 days, the risk of them requiring it at more than a year goes up. Now, I think a natural question is it that if the medication is given for more than 3 days, that creates the scenario where the patient requires it at the year, or is it that patients I believe this falls under the categorization of selection bias. Or is it that patients who have more severe pain complaints are going to require more than 3 days medication, and they're naturally going to be requiring medications at that 1 year mark? I think that there's probably a little bit of both, but to the best of our abilities, if a patient comes in with a pain complaint, especially an acute pain complaint, we want to try to limit the amount of medication. And certainly 10 years ago, if a patient showed up to an emergency room with a back strain or a sprained ankle, I don't think that people would have been as concerned with giving a week to a 10-day prescription of an opioid, whereas today I think that we try to not give that an opioid prescription at all, or to give a short duration prescription. Next slide, please. So this is a very interesting slide, and it's important to note that this survey was taken prior to CDC guidelines being released. But if you look all the way to the left, you can see that 1% of the physicians surveyed prescribed for 3 days or less. So prior to these guidelines being released, it really wasn't the typical way that clinicians wrote these prescriptions. If you look, 70% prescribed for a week or longer. So I think this truly is a paradigm shift. And to get back to the initial point, which is, well, God forbid a patient is in a motor vehicle accident, they're going to get more than a 3-day prescription. And if it was a severe motor vehicle accident, the odds are they're going to require it at a year, but that doesn't really have to do with that initial prescription that was written for them. Yes, that's a true statement. But at the same time, there are the patients that come in with what are trivial complaints or time-limited complaints, and now that we have the sensitivity to understand the risk associated with this medication, I think we could perhaps make decisions about providing less medication and giving the patient less exposure to these medications, and hopefully that changes the amount of patients that are getting addicted to these substances. Next slide, please. Recommendation number 7. Clinicians should evaluate benefits and harms with patients within 1 to 4 weeks. So this is about having that initial conversation with the patient and making them understand that these medications carry substantial risks, and there has to be a really good justification for continued use, including functional goals. And after starting it, the patient should be seen. It shouldn't be, well, I hope this turns out okay, and call me if there's an issue. There should be a concrete follow-up thereafter to make sure that things are heading in the right direction. And then if the clinician decides that the patient is a candidate for long-term opioid management, that the benefits and harms should be reviewed every 3 months. And this, I think, is one of the most challenging parts of managing a patient's pain complaints with opioids, is for the clinician to embrace the power of no, and that is to really internalize and to have the patient understand that really at any point these medications can be discontinued if they're not being used properly or if proper goals aren't being met. But I think that has to be the new paradigm that we use when using these medications, and for the prescription not to be this automatic refill on a monthly basis, which certainly I think was the standard a decade ago for many, many clinicians. Next slide, please. Recommendation number 8. Before starting and periodically during continuation of opioid therapy, clinicians should evaluate risk factors for opioid-related harms. And the next slide is going to show a little more detail on that, where clinicians should incorporate into the management plan strategies to mitigate risk. So on the next slide, we'll actually go through what those various risk factors could be, and then the use of naloxone. And so let's go to the following number of slides, and that way we can drill down on each one of these. So increased risk of opioid-related harms is present with several co-occurring issues such as pregnancy and comorbidities such as apnea in the elderly. Also, if there are coexisting psychiatric illnesses. So these are important things to identify in the chart, and I think that there is going to be, while there already is substantial movement in the electronic health record space for a lot of these things to be identified, and hopefully the clinician using them can be aided in making the decision after identifying these increased risks. But for those who don't have the electronic health record, I think a familiarity with your patient, knowing what the past medical history is, these are things that most clinicians naturally use when they make management decisions. So it's a matter of being aware of these various categories of increased risk and applying them appropriately to the given patient. Next slide, please. Other risk factors for prescription opioid pain relief abuse There's a separate slide that addresses this, but use of the prescription monitoring database, taking high daily dosage of prescription opioid pain relievers, having psychiatric illness or a history of substance abuse, and then living in rural areas and having low income. Now, just because a patient lives in a rural area or has a low income does not make them a person who is a drug abuser, but these are issues that need to be considered when prescribing these medications. I think, interestingly, one of the issues that the opioid epidemic and both prescription and heroin has taught us is that there really isn't any particular group that is protected from this. Previously, there were subgroups that did not seem to be impacted by other substance abuse issues, such as females or those who were privately insured, those of higher socioeconomic status. But unfortunately, this affliction is really impacting all groups. So you have to keep a keen eye out for all patients in this for this particular problem. Next slide, please. Now, this slide, as well as the slide that I showed earlier, which showed that only 1% prescribed for 3 days or less, these are prior to the release of the CDC guidelines. But if you look at the orange bolded bars in the middle of the slide, checking the prescription drug monitoring program, screening for family history of addiction, these were things that were not routinely asked and really need to be asked prior to initiating this, any medications. Next slide, please. So the use of risk assessment tools. If you look at the right-hand side of the slide, opioid conversion, those equivalence tables are invaluable. I gave sort of a practical tip as to how to use that if you don't have electronic health record. I know certainly that EPIC, which I think is 55% of electronic health records in the country, or some large number, is releasing a morphine mill equivalent calculator, I think next year. Other electronic health records are following suit. As far as the opioid risk tools, there are a number of opioid risk tools out there, and they may not be 100% effective, primarily because they're subjective tools. They ask, if you ask a patient who is drug seeking whether or not they have a history of substance abuse, or whether or not they have a family history of substance abuse, sometimes you'll be dealing with a sophisticated patient who will know not to answer that question in a forthcoming manner. Also, some of the popular opioid risk tools ask questions about sexual abuse, which a patient may not be comfortable disclosing. So these tools have some weaknesses. There are other, I think, more data or objective data-driven types of metrics, such as the prescription monitoring database, urine toxicology screens, that can help assess the risk and help you make a decision as well. Next slide, please. Okay, so let's talk about naloxone. So this reverses the effects of opioids, and it has few contraindications or side effects, and it really should be prescribed for patients at risk for overdose. And the CDC provided some guidance on which patients should be getting this medication: history of overdose, history of substance use disorder, higher opioid dosages, and concurrent benzodiazepine use. But this is something that clinicians should be giving to patients in those scenarios. Unfortunately, when a patient needs this, they may not be able to do it themselves. So I think a practical conversation about having it available in the living quarters, having other people aware that it's there, and knowing how to use it can be really effective and can save somebody's life. So I know that successful naloxone distribution programs for opioid users, family members, and first responders has saved more than 10,000 lives since 1996. So this can really be an effective medication. One of the things to tell patients is not to be afraid to redose or increase the dose for a suboptimal response. Next slide, please. Recommendation number 9, prescription monitoring database. So clinicians should review this when starting opioid therapy for chronic pain, and should review it periodically during opioid therapy for chronic pain. I know that in the state of Texas, starting in September of 2019, all clinicians are going to be required to check this prior to prescribing opioids. I listed 3 states that have mandatory PMP or PDMP, those are interchangeable terms, regulations, and those states have shown some really phenomenal improvements in doctor shopping, although that is only, PMP is not necessarily a perfect tool, but it is a very effective tool. And for those who don't know, the prescription monitoring program is a centralized program typically run by the state that lists all of the controlled substance prescriptions that belong to any given patient, regardless of which pharmacy they got it to. So, if you think about the things that we request from a pain patient, where they only go to one pharmacy, that we are the only clinician for them, and that should be part of the opioid agreement. This is a way to make sure that they aren't getting prescriptions elsewhere. Next slide, please. And this is an example of the Illinois Prescription Monitoring Program. So if prescriptions from multiple sources, high dosages, or dangerous combinations, we're trying to destigmatize substance use disorders. We're trying to help facilitate patients who are having a difficult time get care. So ideally, we don't dismiss these patients from care. There are a number of ways to intervene. I know this can be a very challenging patient population. I've identified a couple of clinicians in my community who I can readily refer these patients to, both for inpatient and outpatient programs, if the circumstances require that they be referred out. But I think that you have to view these types of situations as opportunities to really step in and save a life. So although it can be really challenging, the CDC recommendations encourage all of us to try to help in this type of situation. And I'll just say from personal experience, you can really help people out in really dire straits. And, oftentimes it's that moment where a patient is willing to listen. That oftentimes if you have a patient who is doctor shopping or, has something about the way they're consuming pain medications that's not right, they're oftentimes have convinced themselves that it's going to be okay, that what they're doing is okay. And when they're confronted with a clinician who has the knowledge of what they're doing, that can really be a powerful moment where sometimes they're just really cut off from admitting that anything's going on or dealing with you. But I've had multiple instances where that is the moment where they're actually really willing to listen, and proper intervention and having either the tools yourself or having somebody to readily and quickly refer them to can really change somebody's life. So I put what does the Illinois Medical Board say, because both the California Medical Board and the Texas Medical Board strongly encourages the use of referrals out to addiction programs. And the CDC recommendations are very encouraging of the clinician to take these types of scenarios on themselves. So it's important to know what your medical board says primarily because you just want to document your decision-making process and make sure that it's compliant. Next slide, please. So recommendation number 10, urine drug testing. So before starting opioid therapy, and then at least annually, this should be randomized. Sophisticated patients, if it's scheduled, you will not identify problems. It's very important to familiarize yourself with the metabolites of the controlled substances, because there can be false positives and false negatives. So if you do get results back and they seem not to line up, and these are very easily accessible online. If you use Google a reference point, and there are several university labs which provide these resources. Just make sure that you are reading it correctly and not attributing something to a patient that's inappropriate. With urine drug testing, it's not just the presence of substances that you don't expect on it. If you're prescribing a patient medication and the urine drug testing comes back clean, that is also very concerning. So, it's not just a matter of identifying illicit substances or medications you didn't prescribe. You really have to have a game plan of how you're going to deal with the results of this urine drug screen, and it's better to have clinic policies and implement them when appropriate. Next slide, please. So clinicians should avoid prescribing opioid pain medications and benzodiazepines concurrently. I think the benzodiazepine crisis is the next crisis that we're going to be dealing with, because these medications are prescribed very frequently and at very high doses. And unfortunately, you'll often see patients on both of these medications, and sometimes with Soma as the third medication, which is a medication I really don't like at all. I do not have any patients on Soma. I discourage the use of it. There are other good muscle relaxants. But to get back to recommendation number 11, if one of these medications is on board, then the other should hopefully not be initiated. And this is another great use of the prescription monitoring database, because benzodiazepines are controlled substances. So even if a patient forgets to write that in the medication column, that will be readily available information on the PMP, and it can help you make a decision. If somebody is already on one of these medications, ideally you can go in a different direction if you feel that they require treatment either for anxiety or sleep issues or for pain. Next slide, please. Clinicians should offer a range evidence-based treatment, such as medication-assisted treatment for patients with opioid use disorder. I have a couple of slides of additional information on this. Please go to the next slide. So substance use disorder is the phrase that is the new language around somebody who you suspect is addicted to opioids. And if you look, there's a definition here. Substance use disorders range from opioids to alcohol. It causes clinically and functionally significant impairment, such as health problems, disability, and failure to meet major responsibilities at work, school, or home. And it's based on evidence of impaired control, social impairment, risky use, and pharmacologic criteria. Now, this can be a difficult diagnosis to hand out, and I can tell you in my own scope of practice, I've oftentimes questioned whether or not this is present or not. But you have that gut feeling. You have that feeling when you're evaluating the patient if they may be running into trouble, and that might be the time when you call in a colleague to help you with this issue. So, I would rely on your gut feeling on this, and not necessarily by the technical definition of this issue. Next slide, please. So, medication-assisted treatment. So, this has the best outcomes based on the literature at this point. There are 4 treatment options for substance use disorder. One is detox and abstinence. One is detox and a monthly shot of naltrexone. There's medication-assisted treatment with buprenorphine and medication-assisted treatment with methadone. Next slide, please. And if you look, the medication-assisted treatment has the best outcomes. If you don't use the medication-assisted treatment, the rate of recidivism is very high, and the rate of poor outcomes is very high. So as best we can, it's great to identify either resources in the community to help with medication-assisted treatment. I know that there is a waiver program, so primary care, and I was just looking at the SAMHSA website today, nurse practitioners as well is what they're posting, can administer MAT. So this may be something that is good for your own clinic and your own patients, but certainly identify somebody in the community that you can refer these patients to for this. I have to say that I've had some really outstanding outcomes with medication-assisted treatment. One of the things that is really great about buprenorphine is that it actually has some pain management qualities. So I'm a pain management specialist, and a lot of the patients that come to me are very concerned about coming off their medication because the pain will still be there. Even if all these peripheral issues are dealt with, the pain will be there. And medication-assisted treatment both deals with the substance use disorder component of it, but it also provides, in many cases, effective pain relief. So it can really be a good fit for a lot of different patients. Next slide, please. So the opioid analgesics, prior slide. There we go. So the opioid analgesics, this is a really important slide. The opioid analgesics have a lot of baggage associated with them. And the reason why this is important is both to be able to identify side effects, but we're going to be getting to a set of slides which talk about tapering patients off their opioids. And the question is, well, how do you get a patient to agree to taper off their opioids? Or how do you get a patient to agree to come off of their opioids? And I have found that a discussion of the side effects and an improvement in the side effect profile is really one of the most effective ways to have a patient try it. Because rarely does a patient come in and tell you, help me get off these medications. It's oftentimes you have to convince them that this is something that they want to do. But if you talk about most patients who are on opioids will admit to you that they're not cognitively where they used to be, that their mood is different, that even maybe their personality has changed, they don't sleep as well, they're fatigued during the day, they have stomach issues, they can have substantial constipation with hemorrhoids and bleeding. It certainly can impact gait. People have fallen. It impacts the elderly to a great extent in this way. In some cases, it can actually make the pain worse through a mechanism called opioid-induced hyperalgesia. It can impact sexual function through causing hypogonadism. So, when I talk to patients about what they could potentially get for coming off these medications, I go through these various things, and in my experience, they feel improvement in some of these areas pretty quickly. And many of my successes in medication-assisted treatment with patients who come in with chronic pain are because they recognize that they're thinking more clearly, they're back to their old selves, they're sleeping okay, their balance is better, they're sexual beings once more. All of these things really contribute to them making the decision and them continuing on that path. I sent a lot of patients for medication-assisted treatment, and I've had, my odds of continuation I think are better than I expected. And the things that surprise me about it are, one, that patients have told me to a large extent that their pain management is at least as good on MAT. But the other thing that has surprised me is that in the patients that have told me that their pain management is not as good, the reason why they don't want to go back is because of the side effect reason. So I think that having this type of discussion with patients, it sets the stage for them being willing to come off the medication, and once they recognize that that these side effects have gone away, it's a way to keep them off these medications. Next slide, please. So this is a summary of some of the important points that we've just gone through. So we want to use non-opioid therapies first. We do not want to use opioids routinely for chronic pain, but with that being said, there are patients that are legitimate candidates for these medications and will require opioids on an ongoing basis. For those patients, we want to, and for anybody we start on opioids, we want to assess risk and harms. We want to start low and go slow. You want to begin with 3 days or less with acute pain, and we want to monitor, and really you want to have the ability to discontinue the medication when you feel that it's not working, even if it's several weeks, several months, or several years down the line. Next slide, please. This is another set of opioid safety principles geared towards patients. When they survey patients, you'd be really surprised at how much patients either don't appreciate how dangerous these medications are. Sometimes they don't appreciate that there's actually opioid in their Vicodin or their Norco. They don't appreciate the fact that just leaving these medications around is dangerous, or taking them with other substances is dangerous. So I think that we assume a lot as far as patient sophistication goes, but it's just important to hammer home these points because a lot of patients, when surveyed, really don't understand what they're dealing with. So this is by the American Academy of Pain Medicine, and this is something good to post around the office, or to reinforce with patients when you have the opportunity. So one is never take an opioid pain medication that is not prescribed to you. You'd be amazed at how many patients have done that. Never adjust your own dose. Again, that's something that I make sure patients understand on my first visit that they can't do. Never mix with alcohol. Again, if you ask a patient, you'd be amazed at how many times they do that. Using sleep aids and anxiety medications with opioids is dangerous. Next slide, please. Always disclose all of your medications to your providers. Keep track of when you take medications. Keep medications in a safe place, and dispose of unused medications. That disposal issue is key. I think many patients just keep the medications around for quote unquote a rainy day, and don't understand that they are really keeping a dangerous substance around in their medicine cabinet, and if a child were to get their hands on it, God forbid, it could result in a really poor outcome. Next slide, please. So let's talk about the alternatives here. So a lot of these medications are medications that I think we're all very familiar with, but I'm going to speak a little bit about how we aren't necessarily aware of just how effective these medications can be. So the nonsteroidal anti-inflammatory drugs can be really effective, and I'm going to show a couple of slides which demonstrate just how effective they can be. In the case of the NSAIDs, they are a medication that really addresses the mechanisms of pain in a very effective way. They're anti-inflammatory. So when you take an opioid, it doesn't really address the mechanism of pain. It operates via a different mechanism that provides pain relief, but the NSAIDs actually are anti-inflammatory, so they can be really effective in pain relief. The side effects, of course, most commonly are GI upset. You can have some renal issues. They can also raise the risk of cardiovascular events as well as stroke events. A proper consideration of risks and benefits should be done for all medications, not just opioids. Acetaminophen can also be a very effective pain medication for management of pain. The FDA increased the dosing limits to 4 grams. Last year it was 3 grams for several years, but now it's back up to 4 grams. And I have slides that address the other medications on this listing, I think, other than the muscle relaxants. So muscle relaxants, Flexeril, Scalaxin, and Xanaflex. These can be very effective medications. They can also be sedating, so you have to be careful with these medications and make sure patients understand that it can have that type of impact, but I would really discourage the use of Soma. So let's speak a little bit more about the effectiveness of these medications on the coming slides. Okay, so there's a concept of numbers needed to treat. So that's N&T. That's the number of people who must be treated by a specific intervention for one person to receive a certain effect, and we're typically looking for that to be a 50% pain relief. So if you think of that, if there's an N&T of 1, that means for every patient who gets a treatment, that patient gets relief. So N&T of 1.5 that means 2 out of 3. N&T of 2.5 is also pretty good. So lower numbers are more effective. Next slide, please. So this is a very interesting slide. The first thing I'd want you to look at is if you look all the way to the left, acetaminophen 500 plus ibuprofen 200, that's all the way to the left. The blue hand column is the actual efficacy, and the green is the prescribers ranked as most effective. So the combination of acetaminophen and ibuprofen is the most effective therapy on this chart, but it was not what was predicted to be the most effective by treaters. If you look at, now let's look at this at the bright orange. % of treaters believe these opioids to be the most effective way to treat pain. So that would be morphine 10 milligrams and oxycodone 15 milligrams. But when compared against acetaminophen and ibuprofen, and this is Cochrane research, this is published in a good journal, reviewed, that acetaminophen and ibuprofen is more effective than what most clinicians perceive to be the most effective tool. So even though we're all very familiar with acetaminophen and ibuprofen, it's time to, I think, revisit these types of medications, and in combination, they can really be effective. One of the benefits of the combination is that if you look at acetaminophen 500 and ibuprofen 200, those are both lower doses, I think, than what most patients would take if they were only using one agent. So that allows us to decrease the side effect profile of each of those medications. Now, if you go past that figure all the way on the left, the next most effective is ibuprofen 400 milligrams, and then the next is ibuprofen 200 milligrams. So we have to get to acetaminophen plus oxycodone, and that's already the fourth, and it's tied with ibuprofen, mind you, but we're already 4 medications in prior to getting to an opioid. So even though we're saying in many cases no to opioids, I think that there are very effective therapies out there that maybe have been underutilized up until this point, but it requires us to change our attitudes about it because many of us perceive the opioids to sort of be the king painkiller out there when there are better alternatives and relatively safer alternatives. Next slide, please. This is just a reiteration of what you saw on that prior slide, which is that acetaminophen and ibuprofen in the orange all the way on the left is more effective than an opioid, and immediately to the right of that orange column is ibuprofen 400 milligram, and immediately to the right of that is ibuprofen 200 milligrams. So there are options here for us to treat patients to get that pain relief without going to that opioid step. Next slide, please. To review some of the other medications that I had listed, the tricyclic antidepressants, this includes nortriptyline, amitriptyline. So this can be used once daily to prevent and treat pain. One of the things I like most about this medication is actually the final point on the left-hand side of benefits, which is it can help patients sleep. When a patient comes in and they have a pain complaint, you're looking for a solid victory to help the patient get through their day. And also it gives them confidence that you as a clinician know what you're doing. And getting a patient effective sleep subtracts up to 8 hours of pain from the patient's day. So that's, I think, a really effective way just to get it started on the right foot by helping the patient sleep. So I'm a fan of the tricyclic antidepressants. And they only have to be taken at night. The sedative effects typically come up front, so it helps the patient sleep. Hopefully it will not bleed over to the next day, so they won't have daytime sedation. The numbers needed to treat are 3. So less anticholinergic action is present with imipramine and nortriptyline, so I'll often start with nortriptyline. Interestingly, the anticholinergic activity may be tied to the efficacy. So amitriptyline may be more effective than nortriptyline, but it also has a little bit of a worse side effect. So these are things to keep track of. I would be particularly careful with tricyclics in the elderly because it can cause gait disturbance, cognitive issues. You have to look out for dry mouth, dizziness. There can also be some cardiovascular effects. These are rare side effects, but these are side effects to keep track of. So, although we're making recommendations for other treatments, certainly every medication has its risks and benefits. Next slide, please. There's also the serotonin norepinephrine reuptake inhibitors such as Cymbalta. These also can be used daily. They can be used up to twice a day. They're very good for neuropathic pain syndrome symptoms. The NNT is similar to the tricyclic antidepressants. The risk profile is similar to tricyclic antidepressants as well. You have to look out for elevations of plasma glucose, or potentially there being abnormal LFTs. One of the interesting things with SNRIs, I remember when they were first introduced, if you start this medication, which really can be very effective in a lot of patients, and I use it quite a bit, I use this class quite a bit, it actually can have a withdrawal profile. Patients can go through withdrawal when they come off of it. So this is not a medication just to take away in one day. I would take patients off of it over the course of a couple days. Next slide, please. With that being said, I was a Prilosec taker, and I came off of Prilosec and actually had a withdrawal on Prilosec. So I think there are a lot of medications out there that could potentially have a withdrawal syndrome attached, and that's not necessarily an upfront reason not to try it. There's also the anti-seizure medications. This is gabapentin, Lyrica. In appropriate patients, it can be Topamax. This can be used also to prevent or treat pain. The dosing is typically 2 to 3 times per day. The NNTs are similar to those other 2 medications, and for the sake of time, I've tried to put the most common risks associated with all these medications. But certainly prior to administering any given medication, it's important to review the most important risks. But dizziness, somnolence, certainly with Neurontin and Lyrica, you can get peripheral edema. These are things to keep track of with these medications. Next slide, please. The topical analgesics, these can be less efficacious, but the risk profile is pretty favorable. So, using topical lidocaine or topical NSAID, those are, I think, definitely worth trying. I have had some victories with those treatments. Next slide, please. So, it's really important for us to get back into the non-pharmacologic treatments. I'd say out of everything present here, physical therapy is critical. One of the keys to hit with patients on physical therapy is that it should be the beginning of them embracing exercise. So they need to learn the lessons of what they're being taught in physical therapy, minus the bells and the whistles, and continue some level of activity outside of it. If they're just going to go for a week or 2 of guided exercise, that is not really the ideal way for physical therapy to be used. There's also pain psychology with patients for patients with chronic pain. You can help them develop coping strategies, which can be very effective. Acupuncture can be really effective for a bunch of different types of pain conditions, and will be covered by insurance in a lot of instances. Next slide, please. There are a lot of other things that are easy and can be either inexpensive or completely free, such as applying cold and heat, using ways to divert their attention, modifying their environment, positioning themselves properly in bed, using guided imagery and relaxation techniques, diet and exercise. So, but many of these require a patient commitment. But really, when the patient commits, these can be really excellent modalities. Next slide, please. There's also interventional therapies for pain. And there are different types of injections: diagnostic, prognostic, and therapeutic. So an example would be a selective nerve root block. If a patient is having what you think is a pinched nerve from a back problem. So, for example, say somebody had a herniated disc at L4, L5, and L5S1, and they had pain and numbness radiating down their leg. An interventional pain doctor could inject either one or both of those nerve roots, and that could help diagnose if a radiculopathy was present, but it could also be therapeutic. There's some steroid mixed in there. It can give the patient up to several months of relief. There's also what are called medial branch blocks for patients who have arthritis in their back. You can inject some numbing medication over it, and it can give you a sense as to whether or not a rhizotomy procedure can be helpful. So there are a bunch of different injection types that can be very helpful for this patient population. Unfortunately, there isn't phenomenal evidence on these different types of treatment modalities, but there have been clinical guidelines that have been developed, and there is evidence-based medicine that is supportive in the use of these procedures. I pose the question, injection versus chronic use of opioids. If you can get a patient's pain under control with interval injections, it can be preferable in many cases. Next slide, please. And I just listed here just a couple of the treatment modalities available. A lot of these things can be done by a primary care practitioner in their office, such as trigger point injections or musculoskeletal injections. And then there are things that require a little bit more intensive training. There are treatments particular to the spine, and there are actually implantable techniques, neuromodulation such as spinal cord stimulators or implantable pain pumps that can help patients with chronic pain that can be really very helpful. Next slide, please. The inherited patient. This can be a really challenging patient, and I just want to go through some key points. Next slide, please. So when you inherit a patient on opioids, especially high-dose opioids, that first visit is really very challenging because you don't have the time to establish the relationship and the trust that I think is almost required for what you're going to ask of that patient. I wouldn't just naturally continue the treatment that was handed to you by another clinician. But there's a couple of important steps. What the patient says they're on needs to be confirmed, both the medication and the dosage. There's a couple different tools for that. Direct correspondence with the referring or treating clinician is really critical. Now, I've certainly been in a situation where a doctor either is too busy during their day to call me back, or if I somehow never hear from them at all, even though I've left multiple messages. So requesting medical records can supplement that. Also checking the prescription monitoring database is helpful. And then the urine toxicology screen is critical in that moment. If a patient comes in and tells me, I'm on all these medications, I need it every day, and then I do a urine tox screen and it comes up negative, and they say, oh, but and then ex post facto they tell me, well, I just happened to, run out and I haven't been on it for a couple of days. That would be really important information for me to get prior to doing the urine tox screen and not after it. So I think you have to use all these small clues to help make a decision. Next step, please. Next slide, please. So there's a lot of things that you would like to accomplish in that initial patient interaction. And the common denominator is clear communication. The patient really has to really invest in you, and you have to let the patient know that it's going to be a partnership, both and you're going to make decisions together. And there's a lot of endpoints here that can be successful. I think first and foremost, you want to reassure the patient. You want to make sure they understand that there are other treatment options. I think that a discussion of the side effect profile is something that can oftentimes get them to listen to you. Discussing risks and benefits of opioids can also get them to listen to you. Ideally, you want to taper them off the medication if you feel it's not appropriate. If you feel that it's appropriate to continue, that's a decision that each clinician needs to make for themselves. But even lowering doses of opioids can be a really effective step. So it doesn't have to all come off. It can just get to a lower dose. Next slide, please. So, knowing what the patient concerns are going in and acknowledging the patient concerns, I think, can go a long way. So most patients will tell you that they wish they could get off opioids. Now, you have to be careful because a drug-seeking patient or a manipulative patient will say that because it's a nice talking point. But the literature shows that most patients who are on opioids really prefer not to be on them, but feel that they need them. But they fear the pain and they fear the withdrawal. Those are the two of the most common things that they fear about getting off opioids. They also fear judgment by their friends and family. So, and I've had this happen when I'm trying to have a frank conversation with a patient who comes in on an opioid regimen that I don't agree with. I get lumped in with that group. I've been told, you don't believe that I have pain, or they, and then it becomes a much harder task to convince them to see things your way. So acknowledging these concerns up front and, becoming the patient's ally, I think, is critical. Certainly certainly throughout the entire cycle of patient care, but in that first visit, it really is paramount. The patient's also worried that nobody believes them about pain, and that can be something they throw back at you if you say, I really want to change the way this is being managed. That's something that they may say to you as well. So I think part of this is if you sort of preemptively acknowledge these things, it brings the patient on your side, but it also changes. It frames the conversation a certain way where they won't come back and say these things to you. Next slide, please. So the taper, and this can be complicated. There's a lot of different ways to do it, but I'm going to give a couple tips on how to do this. So the longer the patient's on opioids, the slower it should be. If patients are taking opioids as needed on a non-daily basis, they can oftentimes have the medications just discontinued. In that prior example I gave of the patient who comes in on, with all these amazing requirements for opioids, and then the urine toxicology screen happens to be negative, that might be an opportunity for the medication just to be stopped at that point. The goal may be to get to safer doses and not discontinuation. There are many instances, you have to really design the taper for the specific patient. If they're anxious, depending on the duration of therapy and also their comorbidities. And then I think having a frank conversation about the risk of withdrawal is really important, but it's important to explain to the patient that, while you're going through the taper, the pain may be somewhat worse, you may have some withdrawal symptoms, but these are temporary things, and then there are tremendous gains on the other side of it. And going back to the side effects of the medication, is one way to help a patient understand that there's a lot that they benefit from getting off this medication. They're not just losing something, they're gaining a whole lot more. Next slide, please. There's really no consensus on one method of tapering. One way is to decrease by 10% of the original dose. That's usually well tolerated with minimal physiological adverse effects. Oftentimes patients who are on long-acting opioids also have a short-acting opioid for breakthrough pain. I would target the long-acting opioid first and then get to the short-acting. You may want to convert all the medications into short-acting, and that can, at a certain point, and that can help organize the taper. Some tolerate more rapid taper, and you can decrease by a greater amount. But tapering of less than 20% usually minimizes the withdrawal symptoms. And then once you get to the lowest possible dose, you can consider increasing the interval of dosing. I know certainly towards the end of taper, patients start getting the withdrawal symptoms as the body starts realizing it's not going to get this medication regularly anymore. So that's the time where you may want to slow it down, or depending on the patient's personality, you may want to tell them, look, we could just go through this and get it done with. But that, I think, requires a conversation and should be tailored to the specific patient. It is okay to pause, to restart, and to change methodologies. And remember, just decreasing the medication is a victory in and of itself. Next slide, please. So if a patient overdoses, then you really want to rapidly taper that medication. I put down as the next thing, consider formal detox on an inpatient or outpatient program. I am a huge fan of that. I know sometimes patients don't have proper insurance for that, but sometimes you need a rapid taper. Sometimes the patient is having difficulty with slow taper. Sometimes you or the patient prefers it. I'm a huge advocate of getting the patient into the right setting so this can be done. There are clinicians who do this as their full-time job, and they're really experts at it. So I tend to use outside resources as much as I possibly can if the circumstances are right. And then in all cases, optimize the non-opioid pain management. We went through a lot of the treatment options. You want to do your best to help manage the pain while it's happening. And then you want to ensure psychosocial support is present, because it's not going to be an easy process for the patient necessarily. You want to make sure they have the proper support. Next slide, please. Now, the opioids oftentimes are treating comorbidities such as anxiety and depression. So, or there may be a substance use disorder there. So as you begin the tapering process, you may unmask some other issues that are present. And that's, one of the reasons why having good support is necessary, and why you should have some colleagues that you can rely on, whether they're psychiatrists or substance use or addiction specialists, hopefully someone in the community, even if the insurance isn't there, can help you out, or have an emergency room which you can send patients to in the instance that things aren't going smoothly. You want to make sure that you tell patients about what withdrawal is, and make them aware that they're going to have some difficulty sleeping, possibly some increased pain, but it's key not to add other controlled substances to the taper. I remember earlier in my career when I first started out, I would use benzodiazepines to assist with the taper, but then I would be stuck with the patient on benzodiazepines, and whatever you started with, they would get to that last week and they'd require more. They would habituate to what you put them on, and then, I certainly developed referral techniques over the course of time, but there were some instances where I had a patient only on opioids, and I wound up with a patient on both opioids and benzos as I was trying to improve the situation. Of course, I referred that patient outwards, but just you have to be very careful as you add other substances. I would encourage not to do it. And then, I think this is probably the third time I'm mentioning soma in my talk because I don't like it, but I do not like soma. Please do not add soma to the situation. Next slide, please. And then there's some tapering resources that are out there. Again, there are many different ways to do this. There's not just one way to do it. So here are some of the resources that are listed. Next slide, please. So a couple of challenges. So the next crisis is here. I did an informal survey in the Houston Methodist healthcare system, and many primary care doctors are opting out from pain management altogether. So I think that it's really important that we just figure out a better way to manage pain and not just say, I'm not going to manage pain, I'm not going to give opioids to any of my patients. CDC guidelines were never meant to be a legal standard. So, that I think is an emerging challenge. These are recommendations. I think they're very helpful as recommendations, but they're not meant to be a legal standard. I think doctors are really scared about the current climate. There's, regulation and in many cases overregulation. There's also, it's very punitive where, if you don't do something or, if you give opioids, you could potentially get in trouble. So I think that leads to the next crisis, which is my first talking point there. But I think ideally we should incentivize people. We should make insurance make other treatments more readily accessible, and that way we will help doctors and patients tackle this problem. Providing timely access to care, and I said this multiple times, but insurance must approve access to other treatments in order for us to utilize other treatments. Coordinating efforts between different clinicians, between ER and doctors, setting some sort of universal standard. I know that we're designing our electronic health record, and we're trying to set up what morphine MME table, what morphine mill equivalent table we're going to be using for conversion of opioids, and there are multiple tables out there. And while I respect many, different institutions and different organizations' ability to create their own morphine mill equivalent table, I wish we could all come up with one, because that can complicate issues if you're going to be calculating cutoff points. And then changing public perception. I think that as long as we have patients coming in demanding their opioids, it just puts undue pressure on us to try to provide appropriate care. So we really have to re-stigmatize opioids, and we need as much assistance as we can to help us make good management decisions. Next slide. I think this is the final one. This is just a couple of questions to make sure that everybody hopefully got some of the finer points of this talk. Is the relationship between prescription opioids and heroin abuse? There is, but unfortunately heroin is taking on a life of its own at this point. Do the CDC guidelines address controlled substances other than opioids? They do. Benzodiazepines. What recommendations do I put Texas Medical Board chronic pain guidelines contain that the CDC guidelines do not? And that's something that I highlighted with looking up what the Illinois Medical Board says about referring out if you identify substance use disorder versus managing it yourself. When should we prescribe naloxone? I put the SOB50 as that that short moniker to help us all remember what it is. So that's 450 morphine mill equivalents or greater, substance use disorder, and to remember what the other one was, but I can't right now. How many days of pain medication should we try not to exceed on opioid-naive patients with acute pain? That's 3 days. What combination of medication seems to be equally, if not more effective than opioids for acute pain management? That would be the NSAIDs plus acetaminophen, and also just 400 milligrams ibuprofen and 200 milligrams ibuprofen in that head-to-head comparison. And what is the most effective treatment for opioid use disorder? That would be MAT, medication-assisted treatment. And that's my talk.
Thank you, Dr. Fink. There were a couple of questions that were submitted during the talk. I've gone ahead and sent them information on how they could find the answers to those questions. I am going to take control real quick. We have a couple of resource slides. For people who are still on the webinar, in the handout tab, you can print any of these resources. They're listed, as well as you'll receive a copy of the recording of the presentation and a copy of the slides in an email following today's webinar. And then here are some additional resources that are available. We invite you to print out the handouts in the handouts tabs in the left column, as well as look at these resources. If you have questions, please feel free to email Neela Sagalis, Tess Benham, or Dr. Fink directly, and we'll be happy to address your questions. And then the moderator, if you could launch the participant survey, we really would like to hear feedback from you regarding your experiences here today. If you could complete that survey, and then we will be sending a separate survey to all participants asking for your contact information so that we can send you the CME certificates following the presentation. So thank you all very much for joining us today. And this is the end of the presentation, so you can stop the recording, Wendy.